अनम्यूट करो आप.
Muted, unmute yourself.
No, I am not going to PGI these days. I'm working from home.
Okay, because of the COVID thing.
Yeah. If I need to go, then sometimes I go, but mostly I don't go. I had Zoom meeting with my student. I have one student who's doing my project work, emeritus scientist project work. So
Okay.
Ajay Dal is taking care.
Right. Good.
So, morning. We are going to start the session now. Very good morning to all of you on this auspicious day. Auspicious because today is Sharad Purnima, and more so because we are starting today our lecture series on the Nobel Prizes 2020. We from STSTI welcome all the attendees and our associates for the series. As you can see on the poster, our associates are the National Academy of Sciences of India, and we have Professor Sopti, Professor Pasi, who is also from SPSTI, Professor Kohli, Professor K.N. Pathak, and Professor Arun Grover, also SPSTI Vice President. And we also welcome from ICER Mohali, Professor Bagla. Along with me here today is Mr. Dharamveer, President SPSTI, and Mr. M.L. Garg, who is the financial controller of SPSTI. May I now request Professor Grover. Professor Grover?
Not here, right now.
So I consider it a privilege to have an opportunity to welcome all those who have logged in to listen to the first of the series of expository lectures for general audience on the Nobel Prizes 2020. These are being hosted, as you just learned, on behalf of an NGO society, a National Science Academy, and a premier National Science Institute of India. For the organizers, this is a new experiment, but we are determined to sustain it as a defining part of other well-established annual events like the Rose Festival, the Literary Festival, the Sangeet Sammelan, the Theatre Festival, and the Science Congress in the City Beautiful, which indeed is the knowledge hub of the northwest of India. Can you hear me?
Yeah.
Yeah, can you hear me?
Yes, sir. We can.
Yes, sir.
Yes,
You
we
are
can hear you. We can hear you, sir.
So should I proceed? I have completed my...
Yes, you are audible.
A small number of Nobel Prize winners in science get invited to the Indian Science Congress held in the first week of January every year. Ever since the Department of Atomic Energy and the Department of Science and Technology started to send Indian students for participation in Olympiad competitions in mathematics and other science subjects, and the DST started to support organization of Inspire camps for high-performing school students, and awareness about the need for excellence at the highest levels in mathematics and science subjects and as well as in technology has got permeated amongst the teenagers all across India. The newly established Indian Institutes of Science Education and Research have emerged as destinations where Science Olympiad finalists, KVPY scholarship holders, toppers of school boards, and high performers in JEE examination, etc., can gain admission to receive the high quality science education comparable to best globally. Thus, the Homi Bhabha's desire of making available proper environment for studies as well as intelligent financial support to the youth of the country within India stands realized via ISERs of India. The first batches of graduates of ISERs are just entering as faculty members in Indian academic after completing their PhDs from the best of the research institutions and research universities in India and abroad. It is my personal belief that in about 2 decades from now, Indian scientists would start figuring amongst the serious nominations for Nobel Prizes in different subjects. This confidence stems from the fact that every year Indian students do well in the science and the maths Olympiads and bring back several Olympiad medals. I wish to conclude my address by sharing that several members of the governing body of SPSTI were enabled to pursue career in fundamental sciences 5 decades ago by virtue of National Science Talent Search Scholarship Scheme administered by NCERT from mid-1960s to mid-1980s. This scheme offered scholarships from BSc to PhD level to about 300 students. The NSTS students who completed PhD have done exceedingly well as research scientists and faculty members in universities in India and abroad. Some of them have went on to get elected as fellows of the Royal Society in London, become members of the National Academy of Sciences in USA, have become presidents of the science academies in India, etc. One of the NSTS students selected in 1968, namely Venkatraman Ramakrishnan, went on to win Nobel Prize in Chemistry in 2009. He was elected as president of the Royal Society London for a period of 5 years in 2015. In January 2015, he visited ISER Mohali and other institutes in Chandigarh after a gap of 46 years. He had attended a month-long summer school for NSTS scholars in physics at Punjab University in 1969. He had delivered 5 lectures during his visit to Chandigarh in 2015. My optimism that Indian scientists will fulfill the national aspiration that few of them ought to reach the stage of Nobel Prize winners every couple of years. This optimism stems from the fact that the 2 Nobel Prize winners in economics in recent times, namely Professor Amartya Sen and Professor Abhijit Banerjee, not only had studied in India, but they had also taught in the universities of India. Thank you very much, and I have concluded my address.
Thank you, Professor Grover. Now we will present a message, a very brief message from one of the patrons of SPSTI. This message has been sent by Professor Mrigank Sood, a very renowned biologist from MIT, Massachusetts Institute of Technology, USA. Are we ready to play the video? Yes, we will have this brief message. Professor Sood.
Hello, everybody. I'm happy to note that the Society for the Promotion of Science and Technology in India, a society devoted to the popularization of science, has joined hands with the National Academy of Sciences India, Chandigarh chapter, and ISER Mohali, 2 academic entities, to carry out this program on the Nobel Prizes, which has been one of their long-standing programs every year. I understand that they used to take the experts to lecture in various schools and colleges in Chandigarh. This year, however, the format had to be changed due to the pandemic. We expect a larger reach, though, this year because of this and also because of the contribution of the National Academy of Sciences India and ISER Mohali in getting top experts to speak. I'm sure that young people in the audience, as well as members of the Academy, their associates, and people from ICER will enjoy the talks. My best wishes to the National Academy of Sciences India, to ICER Mohali, and to SPSTI for this program, and I welcome Dr. Chawla for this talk.
So, with thanks to Professor, I now request Shri, President SPSTI, to read out a brief introduction to the speaker, Professor Y.K. Chawla.
Professor Dr. Yogesh Chawla served as the director of the Postgraduate Institute of Medical Education and Research, Chandigarh from 2012 to 2017. He had joined as a faculty member in the Department of Hepatology of PGI in 1983 after obtaining his MBBS and MD degrees in gastroenterology from the Netaji Subhash Chandra Bose Medical College, Jabalpur. By virtue of his outstanding contributions as a clinician and as a researcher, he had a material rise in his career and he assumed the headship of the Department of Hepatology at the PGI in 1999 and served at this apex position with distinction under his superannuation until his superannuation in 2017. He was elected Fellow of the National Academy of Medical Sciences of India in 2004 and was awarded in 2005 with prestigious Dr. B.C. Roy Award, the highest recognition given by the Medical Council of India. It may be of interest to the younger people in our audience today that Bharat Ratna, Dr. Vidharchan Roy, was a medical doctor who not only served as the first Chief Minister of West Bengal in independent India, but also got established the first IIT in India in 1951, the Indian Institute of Technology at Kharagpur. Unfortunately, I am one of the alumnus of this institute. Professor Y.K. Chawla has the distinction of being a fellow of American College of Gastroenterology as well. The government of India honored him with the Padma Shri in 2015 for the outstanding contribution he has made to the healthcare. He is currently associated with the Kalinga Institute of Medical Sciences, Bhubaneswar, as chairperson of its academics and the Emeritus Professor. He serves on the governing bodies of several institutes of the country, including the Research Council member of CSIR, Institute of Genomics, and Integrative Biology, New Delhi. Professor Chawla, you are most welcome, and I am delighted to see you to speak to us on such an interesting topic.
Thank you very much, sir. It's a pleasure and an honor for me to be speaking to this great audience and to the students who need to be motivated on the Nobel Prizes that have just gone to the scientists. After leaving PGI, when I joined Bhubaneswar, a great surprise that I went across was that two Nobel laureates during the annual convocation were always invited by the university. So this was something very new to me. In Chandigarh, we had a chance to meet just one or two Nobel laureates, including Venki Ramakrishnan. But there, having been there for 2 years, I've been able to meet four Nobel laureates, and they give motivating lectures to the students there. I hope we are able to do something of that sort in Chandigarh as well. So today, I'm going to talk on the Nobel Prize winners who have got it. I'm not getting the share screen. Can the admin help me out? What do I do for that? Is anyone from the admin there?
Yes, we are working on.
Yeah.
Mahipal Sharma is our admin. He is the computer expert with us.
You should make Professor Chawla a co-host of the meeting, then he will be able to share the screen.
कुछ प्रॉब्लम आ रही है क्या?
Hmm. I'm getting information host disabled attendee screen sharing.
देखो भाई.
Sir, please, we are doing soon.
Okay, fine.
Mahipal sir, please make Professor Chawla as co-host.
Okay. Yes. Hello.
Co-host बनाओ sir जल्दी.
Okay. Got it. Yogesh Chawla. Okay.
Professor Chawla sir, please go ahead.
Okay. Yes. Can you see my screen?
Yes, sure.
Okay. So we get going now. So as we all know that we had 3 recipients of the Nobel Prize this year in medicine and physiology, and I'll on a subject which has been of our interest at PGI for many years. So just to give you a little background about the Nobel Prizes, Alfred Nobel was a Swedish. He was a chemist, engineer, and an industrialist. He invented the dynamite, and to his credit, he had 355 inventions. He purchased the famous Bofors and which has been a major armament manufacturer. He also invented ballistite, which is a smokeless military explosive. He bequeathed all his realizable assets and wanted to make the most prestigious award, that is the Nobel Prize. Although he died in 1886 on the 10th of December, which happens to be the award-winning ceremony. He died at a young age of 63 years, but he executed a will that the prize from his assets would be conferred for the greatest benefit to mankind. So initially there were 5 Nobel Prizes: physics, medicine, literature, peace, and chemistry. And in 1968, the economy prize was introduced. So once a person gets an award, he gets a gold medal, a diploma, and a monetary award, which is equal to almost 8.33 crores rupees. And it is not awarded posthumously. A total of 950 Nobel laureates have been awarded this prize till now from 27 countries, and 42 Nobel laureates have got it more than once. So this award is instituted by the Nobel Foundation, which is a private organization which came into being in the year 1900, and it created a solid funding base, and it has associations and the main constituents, that is the Royal Swedish Academy of Sciences, Karolinska Institute, Swedish Academy, Norwegian Nobel Committee. And they've made some guidelines where they send forms in September to 3,000 nominees. And these are the prominent academicians. They also send to the academic institutes. And by 31st of January, they shortlist about 300 potential names. Finally, they come out with the award. The first Nobel Prize was given in 1901 to a German physiologist who made an antitoxin to the diphtheria by then, which had caused a lot of deaths during that. And he's been Emil von Behring. There were no awards in a few period of time, especially during the World War from 1940 to 1942, and a few sporadic years as well. The youngest Nobel Prize winner is Malala for peace. She's just 17 years from Pakistan. And the oldest has been good enough. He's 97 years and he's got it in chemistry. There have been a few refusals of Nobel Prizes in many years ago. When you go through the numbers and the countries that the people have been given, US has the maximum of 384 Nobel Prizes, UK 132, Germany 108, Sweden 32. And when you look at our region, India has had 11 Nobel laureates, Bangladesh 2, Pakistan 2, and China 8. About 6 to 7 of them have had Nobel prizes multiple times, and one of the examples we all are familiar is Marie Curie and F. Sanger. There have been 6 married couples who've got the Nobel Prizes, and one of them was the recent one, Abhijit Banerjee and Esther Duflo, and Marie and Pierre Curie in 1903 were the other couple, and there are 4 more who have been given the Nobel Prize. This is the list of Indian Nobel laureates. I've added a couple of them more who were not stationed in India but did some work abroad, and we've had 11 Nobel laureates from India. One of the important misses for Nobel getting the Nobel laureate award has been Mohan Chand Gandhi, or Gandhiji, for the peace. But then coming to the main issue today, it was on 5th of October 2020 that 3 individuals, Harvey Alter, Michael Houghton, and Charles Rice, were given the award, Nobel Prize Award, for their discovery of hepatitis C virus. And they all happen to be Americans. So I would take up Charles Rice first because our hepatology department has been associated to a little extent with Charles Rice. He was born in 1952, 68 years of age, did his PhD in 1981, significantly spent his time in California Institute of Technology. He was working on RNA viruses and he had 232 publications. What I need to tell, amongst all the 3 who had given an interview and which was available on the net, everyone got a phone call between 3 and 4 o'clock in the morning. Some of them looked irritated in picking up the phone, but then they were surprised. So this is what Charles Rice had to say. It took us months and months of toil to sequence a viral genome. Now people can do that in a matter of hours. So I think it has taught us a lot of things about science in general. And if there is really a pressing problem, we need to mobilize people all around the world to work on these problems. People would love to have a cure in a week or a vaccine in a week. He further said that, and it's really sort of changing the way science is done to bring about more of a community effort rather than something that one may do solo in isolation. So I thought young virologists of today just have this amazing collection of tools and capabilities to understand what is going on in a virus biology lab and host response at a level that was just never possible. So I'm optimistic that with the success of hepatitis C, I predict a success and getting handle on the current coronavirus. And our connection with Charles Rice was a PhD project being done by Dr. Jyotsna, which ultimately got published in Journal of Medical Virology. And she was working on HCV entry receptors. Dr. Ganguly and Dr. Gulavri were part of the program then. The next person is Harvey Alter. He was born in 1935. He's the eldest of the three, 85 years. Mainly, he worked in New York, had 74 publications, worked in University of Rochester and University of Seattle. But being in the Department of Transfusion Medicine at the National Institute of Health, he got this award. And he got the phone call at 4:45 a.m. in the morning. So what he said is, it's something you don't think until it happens. That also in a period when there is COVID year, where everything is turned upside down. He had a non-directed research hypothesis of what caused post-transfusion hepatitis. And his work was done all at the National Institute of Health for 50 years, along with Professor Purcell. NIH allowed him to go his way, which paid off with effective innovation, which and nobody thereafter, after the identification of post-transfusion hepatitis, got post-transfusion hepatitis. So this was astounding for him. Michael Houghton is 71 years old, born in UK, PhD 77, King's College, worked there, and then he joined Chiron Corporation, which works with the equipments and coming out with new tools. He worked for University of Alberta for a long time in Canada, has had 56 publications, and he got a phone call at 3 o'clock in the morning. So he was very irritated. It was after the 3 phone calls which came repeatedly that he finally gave up. And he said that cloning of HCV took a frustratingly long time. HCV was a pandemic which was killing a lot of people every year. It was a difficult task to discover hepatitis C virus because they didn't have the tools then, and he applied all sorts of methods. They tried 30 different approaches over 7 to 8 years and eventually got one done after screening a lot of clones. He worked with some great people. There was very hard work, and persistence was part of our success story. Louis Pasteur was his inspiration. He was working in a biotech company where he had a lot of pressure to manage the program and keep it going. And after the virus discovery, he developed a blood test quickly. Therapeutics came into existence, which took 20 years. And finally, they are working on a vaccine. So let me take you through the journey of the hepatitis C and from its recognition towards global elimination. Way back in 1960, when people used to have jaundice, they used to call it as infectious hepatitis because there were abnormal liver enzymes like SGOT, SGPT. It was highly contagious. And there was a second group of hepatitis known as serum hepatitis, which usually used to occur following blood and blood products. These patients were, the virus or what caused hepatitis was moderately contagious and produced chronic hepatitis. Way back in 1965, Bloomberg discovered hepatitis B, which is again a part of the post-transfusion hepatitis. And this was initially called as Australia antigen, later on hepatitis B virus. And he got a Nobel Prize in, I think, 1976 for his discovery of hepatitis B. But while the scientists were working on the post-transfusion hepatitis, they studied a huge group of patients who required blood transfusions and mainly who were being taken up for open heart surgery. And they found that the post-transfusion hepatitis was seen in as high as 30% of patients. They found it more common in individuals who received blood from paid donors, about 51%, as compared to voluntary donors, which is now being practiced almost everywhere. And Chandigarh was the first to start it in India. And with screening of hepatitis B in the blood, the post-transfusion hepatitis came down to 9%. Then further, they found that the virus particle which they had identified, they called it as non-A, non-B hepatitis because it was not hepatitis A. They found that when they treated it with chloroform, it did not produce any transmission when they gave it to chimpanzees, because, and then they derived that the virus had a lipid envelope, and that was the reason why it did not help in transmission. But they were closely getting to the hepatitis C virus. They also found that when they gave this infected serum of individuals who had post-transfusion hepatitis, majority of them, after exclusion of hepatitis B, they had low-grade liver enzyme elevation. When biopsy was done, they had mainly mild disease, but 10% of them had cirrhosis. And over 5 years, 20% of them had cirrhosis. And when they gave interferon, which used to be the treatment for hepatitis B, these patients started responding. So it was in 1989 that the virus genome was cloned and sequenced, and it was Houghton who called it as hepatitis C virus. And this came out in a publication in Science in 1989. The Chiron investigators then worked on finding out a method of diagnosing individuals who had hepatitis C infection. They cloned the viral fragment, they characterized the full length genome, which was Houghton who called antigenically distinct. But they found that this was a rapidly replicating virus, with the result that there were a lot of variants. There was a poor proofreading ability for HCV polymerase, and the neutralizing antibodies were only against the dominant strain. But they ultimately were able to find out assay which when done in these patients, decreased the incidence of post-transfusion hepatitis to 0. So most of the transfusions that were done between 1970 to 1990 were possibly not tested for hepatitis C because it wasn't available then. And a lot of the patients who ultimately now present with cirrhosis, they ultimately were able to find out US and other European countries present with cirrhosis liver. I want you to look at all these aspects on the background of COVID, which is happening here. This virus also is a rapidly replicating virus, produces very little of neutralizing antibodies, and hence, when we get the vaccine, how effective it would be is a questionable thing. But the lower diagram that we see here is the genomic structure of the hepatitis C virus, which has different components, and I'll just tell you. This genome has 9,600 nucleotides, and there is some geographical differences in different regions in the length of this hepatitis C virus. It has core, which is the conserved basic protein and is responsible for chronicity. We say chronicity in liver diseases and in most of the other diseases if it persists for more than 6 months. Then there is another component known as E1 and E2. These are the envelopes, and they form the binding protein by which the virus goes into the liver cells or the hepatocytes. There are other non-structural proteins like P7, non-structural 2, which have very limited role to play. The non-structural 3 has helicase and protease, which is has a responsibility in replication. The importance of knowing this is when we come to the drugs for managing these patients, you would be able to understand it better. NS4A is important for cleavage of the primary layer polyprotein. NSB is important for RNA replication, and NS5, the non-structural region 5A and B, is also important for HCV replication. So HCV belongs to the Flaviviridae family, something which yellow fever, Japanese encephalitis, and dengue we all are familiar with. There is a lot of genetic heterogeneity, and that is why there is no single hepatitis C virus. There are almost 8 genotypes, all of which tend to be a little different from each other. Once the virus enters into the liver cells or hepatocytes, it multiplies in the cytoplasm, getting attached to the membranes of endoplasmic reticulum. I won't go into the detail, but what I need for you to see is that it has a very high replicating capacity. It replicates every day to 1.3 by 10 raised to the power of 12 logs, which is almost in crores. So once a hepatitis C virus gets into a liver cell, it multiplies very rapidly and then it causes damage to the liver. And this is what the virus looks like, very much similar to what we have seen with corona, although not so much of the spike proteins, but these are the components, the core, the envelope, and the different glycoproteins. So this is the individual contribution of the three scientists. Harvey Alter, he found out that there was an unknown agent which was responsible for non-A, non-B hepatitis. And this he did from chimpanzee studies where infected individuals' blood was injected to the chimpanzees. Michael Houghton and his collaborators, they worked in the NIH and they were able to find out the first diagnostic test for hepatitis C. And Charles Rice was able to ultimately give proof that HCV alone is responsible for non-A, non-B hepatitis. So let's take you through what is hepatitis C as a problem. It's especially more so in Punjab. And I would like each one of you to learn a little bit about hepatitis C. This, if an individual gets infected, usually is asymptomatic. So there are 8 genotypes, as I mentioned. There are variants in the genome sequence, and genotype 1 and 3 are common in the world. So also in India, genotype 3 is more common than genotype 1. We don't normally see acute infections because since they are asymptomatic, but you can trace a few of the patients if they have had a blood transfusion or if they had a dental extraction, surgery, or some other events where there was blood and blood products entry into an individual. But most of them present to us with chronic infection. So 30% of individuals who have acute HCV infection clear in 6 months without treatment. 70% of them go on to develop chronic infection. The worldwide prevalence is about 1.5 to 2.3%. And now with stricter HCV guidelines and treatment possible, it has come down to 0.9 to 1.5%. It's important to know that it is transmitted by injecting drugs, sharing needles. So it's more common in individuals who are drug addicts. If there is reuse of medical instruments, bad sterilization of equipments, transfusion of unscreened blood and blood products, bad sexual practices, tattooing, and barbers. When you look at the natural history of this disease, when hepatitis C attacks the healthy liver, it causes hepatitis. There is not much damage in this stage. But if you're not able to pick up these patients, they go into a stage of cirrhosis. The liver becomes hard, it becomes nodular, and the functionality of the liver becomes poor. And finally, still, if it is not treated, then these patients land up with liver cancer. So almost 17 to 55% of individuals about 16 to 20 years after they have been infected with hepatitis C develop cirrhosis, and over 20 to 30 years develop liver cancer, 1 to 23%. And the disease progression is faster if an individual is a diabetic, if he consumes alcohol, if there is obesity, is hepatitis B positive, HIV positive, and is on immunosuppression, like patients who've had organ transplantation, liver and kidney, and if the genotype is 3. Usually, as I said, the progression to cirrhosis is very silent. That's why it is called as a silent killer. And these patients come to us in clinical practice with complications of end-stage liver disease. And these complications are swelling over the feet, swelling over the abdomen, known as ascites. They come with jaundice. They come with hepatic encephalopathy and upper GI bleed or black stools. So these are very dreaded complications. And once they occur, the survival of these individuals is just about 40 to 50% over a period of 5 years. These patients need to be treated with liver transplantation, and no other way of therapy improves them. When you look at liver cancer and when you compare with hepatitis B and hepatitis C, hepatitis B is considered to be more predominant in patients with cirrhosis who come to us. Of course, the biggest contribution is alcohol, now being followed by a fatty liver associated with diabetes and obesity. Hepatitis B used to be predominant about 20 years ago, and hepatitis C constitutes 12 to 20%. And similarly, for liver cancer, hepatitis B is predominant, HCV is second to that. But in Punjab and in Chandigarh, that the type of cases we used to get, alcohol cirrhosis was the commonest, followed by hepatitis C, followed by hepatitis B, and then fatty liver disease. But hepatitis C tends to increase the risk of liver cancer 17 times, and especially it's more if the patient has genotype 3, obesity, and diabetes. Hepatitis C is also associated with thyroid inflammation, kidney disease, diabetes. It precipitates diabetes, skin diseases, and even lymphomas. So since this hepatitis C infection was associated with so many harmful effects, treatment came into existence almost about 30 to 35 years ago. And we at that time in PGI used to give these patients interferon, which was very, very cumbersome. A lot of side effects. Patients had to be taken these injections every day, and only 6% of them we could get rid of hepatitis C. And when you gave it for 1 year with all the side effects like body ache, headache, and many other, only 16% of these patients got relief. Then in 1998, ribavirin, which also has been tried in coronavirus, it started showing some improvement when you gave it along with interferons, and the response became 42%. Then a long-acting interferon was available in 2001, where we used to give interferon once in a week, along with ribavirin. The response was 55%. After that, about 10 years after this, protease NS3 and NS4 inhibitors came into existence. And these were telapravir and bocepravir. Success was 70%. Again, a lot of drug interactions and a lot of side effects. So they did not come into the market in a big way. But now since 2016, we have polymerase NS5A and B inhibitors. You must have heard the name of sofosbuvir, ledipasvir, velpatasvir, which clears the hepatitis C virus in 98 to 100%. So much so that you can say that you have cured the patients with these directly acting antivirals. I also need to say that earlier on, the Gilead company, which is making remdesivir for corona, used to charge 1,000 US dollars for one tablet for treating these patients. So you can well imagine how many people would have been able to get treated initially. But then once they transferred the patents to the Indian companies, the treatment has become ridiculously cheap. So this is the timeline, and which I just mentioned from the start of non-A, non-B hepatitis to the final treatment. So what has been the impact? We've been using this for almost about 4 years, the directly acting antivirals. We've been able to achieve reversal of cirrhosis in a small percentage of cases. Cirrhosis was considered to be an irreversible disease, but we've started seeing improvement in these patients when it is given for a long time. These patients of cirrhosis with complications when they had a bleed, hepatic encephalopathy, and ascites, which was not being managed with medicines, they were taken up for transplant. But when you gave these patients these directly acting antivirals, some of them got delisted from liver transplant. That means they improved significantly so much so that they did not require a transplant. So these drugs not only improved the quality of life, but also improved the morbidity and mortality. Some groups of hepatitis C need special attention, those who have associated hepatitis B infection or HIV, because the mode of transmission is the same of hepatitis B and HIV. They need to be treated differently. If those who have had solid organ transplantation, those who have chronic kidney disease, and especially the pediatric population, those who are less than 12 years of age are still not eligible candidates for the directly acting antivirals, DAAs. People have been working on a vaccine for the last 20 years or 25 years in hepatitis C, and they have not been able to come to any vaccine because this is a challenge. Vaccine is always essential to prevent transmission and reinfection, but because of the complex genetic diversity and very rapid replication of this virus, there is always an error in the genetic diversity of the virus. And they have not been able to adequately understand the HCV immune escape. So we are still a little far away from developing a hepatitis C vaccine, hepatitis C, which came to our knowledge way back in 1990s. It's been 30 years and we've not been successful as yet. Now let's come to what is the burden of hepatitis C. According to WHO in 2015, there are about 251 million hepatitis B virus patients and 71 million hepatitis C viral individuals. Almost 4.75 lakh patients die every year because of hepatitis C. And when you look at the estimated prevalence of hepatitis C, it's about 1%. So it's a global disease burden, more commonly seen in the European and Eastern Mediterranean region, usually seen in individuals more than 50 years and 20 to 40 years. And four countries like China, India, Pakistan, and Egypt tend to constitute 40% of the hepatitis C load in the world. One very interesting fact which has come out epidemiologically is the Punjab of India is heavily infested with hepatitis C infection. So also the Punjab of Pakistan is heavily infested with hepatitis C. We don't know what is the reason. We keep on debating about it, but there possibly has to be some genetic association responsible for very high prevalence there. This again gives you a picture of the global estimation of hepatitis C. When you look at India, more than 1% prevalence is seen in Punjab and Manipur. And between 0.5 to 0.99% is seen in the orange bars, Uttar Pradesh, Haryana, Uttarakhand, West Bengal, and 0.25 to 0.49 in other parts of the country, and extremely low in the areas which are marked by green. So when we looked at the hepatitis C prevalence in India, when you look at the community, it's about 0.85%. Blood donors, which is a very selected group, it's about 0.44%. Hemodialysis patients who need to be given blood transfusions have a higher incidence of 19%. People who are injecting drugs, PWID, it's about 44%. Multi-transfuse, that is thalassemics or hemolytic who require blood transfusion every 15 days or a month, it's about 24%. High risk sex behavior, 4%. And those living with HIV is 3.5%. Compare this with hepatitis B prevalence, which is seen, which is a DNA virus prevalence about this is a population-based study in 2 years ago, where they found anti-HCV positivity in 3.6% average. with highest being in Moga, lowest in Gurdaspur. More often in males, rural area, prevalence increased if they have been given blood transfusions, lower educational, and there was regional variation in Punjab because of reuse of syringes, surgery, dental extraction, and increasing number of injection drug abusers. Way back in 2002, the government of India made it mandatory for all blood transfusion centers to do mandatory HCV testing. So this is the picture in Punjab where you would realize that Sangrur, Mansa, Moga, Muktsar, they had very high prevalence, whereas north of Punjab had lesser prevalence of this disease. So with such a high global burden, the WHO in 2015 ventured on hepatitis C elimination. And the WHO said that by 2030, we should be totally rid of hepatitis C. So how do you achieve elimination? You have to diagnose 90% of the individuals who are infected, and those who are diagnosed, 80% of them should be treated. If we do that, the mortality is decreased, the new infections would be reduced. And you need to use affordable, high quality diagnostics. There is a stigma attached to hepatitis C and hepatitis B infection and discrimination also, which has to be taken care of. There is a changing epidemiology of the infected population. Now, young and those without cirrhosis are also being seen, especially because the people who inject drugs are coming more often to us rather than the individuals who had cirrhosis. So it is absolutely important that we should give education and training to the medical health persons. Injections need to be safe, prevent cross-infection, and do patient education. Screening of blood is important, safe injections, decrease unnecessary parenteral medications. Very often we tend to get people who want to have an injection for weakness or one reason or the other. You don't know what type of syringe or needles is being used, especially in the villages. There should be a proper waste management. And these individuals who are diagnosed as hepatitis C should be treated. One should initially start with micro elimination. That means you look at the high risk groups like prisoners, treat them, diagnose them, and treat them so that you start tackling these issues. And when 45 countries were analyzed last year as to what have they done for the WHO recommendation of elimination, they found that 9 countries were on track, 30 yet had to be accelerated. And I'm pleased to say that in India, we have a national viral hepatitis control program by the government of India, which started in the year 2018. Another way by which one can take care of the hepatitis C individuals is the tele-mentoring project known as ECO, which we used for the state of Punjab and is being now used in other states of the country as well, where you train the doctors and the nurses to identify patients with HCV and give the treatment. And if you have any difficulty, you get in touch with the nodal center. Nodal center for Punjab and Chandigarh is PGI. As I said, because of the patents being transferred, the drug therapy has become very, very cheap. And with $60, you can treat the individuals for a 12-week course. So generic drugs have brought the cost much lower, although I would say that elimination is not a simple task. In Punjab, the group from PGI has treated almost 80,000 patients with hepatitis C over the last 3 to 4 years. And free treatment is being given to these individuals, and also by the National Viral Hepatitis Control Program by the Government of India. And in Punjab, 75% of these individuals have completed treatment, and the response rate has been 91%, which is slightly less than what is recorded in the literature. And this is because of treatment interruptions and other issues related. So friends, the take-home message is that non-A, non-B hepatitis C saga, we have now seen the end of the beginning, which started way back in 1970s, and it's the beginning of the end. We used to see a lot of patients in PGI of hepatitis C. Now they are just in the form of a trickle because over the last 4 years in Punjab and adjoining areas, a lot of them have got treated and they don't require to come to the institute. So, what is the message that I need to give? You have to identify a problem. These Nobel laureates identified non-A, non-B hepatitis as a problem. They did a very good teamwork and they had a lot of collaborations, which we all need to do in the current era. All of us, the youngsters and the faculties, everyone. There should be a passion to come to a logical conclusion. These three people were very passionate and they persisted with finding out what was responsible for hepatitis C. And finally, what you saw has been a success story with the directly acting antivirals 4 years ago. And now you have 3 Nobel laureates who have been given the Nobel Prize this year. Thank you very much for the patient hearing. I'll be very happy to answer if there are any questions.
Thank you very much, Professor Chawla. This was indeed enlightening. I learned a lot, and I'm sure all the listeners have. And now it is time for questions.
May I ask one simple question?
Yes, sir.
Yes,
What is the most common way of infection of hepatitis? Most common.
Hepatitis C, initially most common used to be blood transfusion. After mandatory checking, now it is injections getting from the rural doctors or RMPs. Dental could be another possibility, and third could be tattooing and barbers. This is what, with more awareness, we've come to the conclusion that these
Dr.
are.
Chawla, can I ask you, please?
Yes, sir. Sure, sir.
This is Dr. Sopti.
Yes, sir.
Yeah, from your lecture, it's a wonderful lecture. I'll tell later on. My question is, it has taken about 60 years to now go for the treatment with a proper diagnosis. And don't you think that within 2 years, less than 2 year time, this thing has been done with the corona, that we know that we have identified corona, genomic has been done. Now only thing left is to find out a proper drug. And with that, probably, I think this technology has helped us now to go for a proper treatment for corona, which is not far away. Looking from your lectures, the evolution and collaboration, it's really, what do you think?
I agree with you totally, sir. But I think the story would not end with the vaccine unless we have a good antiviral drug about which we have no information as yet. I think there would be some control with vaccine if it produces a good amount of antibodies for a longer period of time. But I'm sure it is much faster than what has happened with hepatitis C.
I'm keeping fingers crossed with vaccine also, because we don't know that how many variants are there. There's just a few of them have been identified, and probably a vaccine developed for population somewhere else may not work for us. And Madhu knows it, that how the polymorphism plays a role in the, the reaction to the drugs or the other things. And I'm keeping my fingers crossed, but still some control will be there.
Yes.
And probably, and another thing, I think Covaxin of the Indian origin may be more helpful if we are using the Indian strain. Don't you think that?
Yes, possible. But then the major point is the antibody levels, how much we get that.
Which one, because there's so many attempts, so many different attempts, DNA, RNA, and so many things are membrane spike protein, and which one will work probably.
What actually surprises me most is even individuals who have had corona, their antibodies are not always positive.
Sure,
so
that's why
it's a very vague virus, and
Yeah.
unless we get good results, I think we are just talking
In a year.
yeah, in a
Yeah.
haze.
It's a notorious virus, I will say
Yes,
that.
absolutely.
It's a totally notorious virus. And see, now more problem is coming with asymptomatic patients.
That's right.
It's much more because why this second wave or third wave is coming, it's
That's
coming from the asymptomatic ones.
very true.
Not
Very
the symptomatic, we know that. But
right.
what the asymptomatic are doing, that's a big problem.
Very true, sir.
But definitely, there's a good lesson from your lecture,
Right.
and that if we do a collaboration and understand each other, we will be quite successful. Not only with Corona, but we have to think of future also.
Very
Because
true.
who knows that Corona 2019 there may be another Corona 2020, because
That's
this
right.
is going to happen. And again, we are not sure whether it's a man-made virus or it's a natural virus. We are
Right.
not sure at the moment,
Right.
because so many stories are coming up. Yes, sir.
That's right. Dr. Pathak,
I want, yes, one
Dr.
small
Pathak,
question.
yes.
You want to say something?
No,
May
no.
I, sir?
I want a small question. Can I ask?
Yes, sir. Sure.
How fatty acid is related to these viruses?
Fatty acids
is related to the viruses.
I think, as I mentioned, for hepatitis C, it has a lipid covering. Fatty acids and responsibility of virus, I'm not sure.
Okay.
The condition which we commonly see now is the fatty liver disease.
Fatty liver, that is what I meant. I meant fatty liver.
So as I mentioned, if there is there is an association of fatty liver disease, which is there in almost 70 to 80% of individuals in India.
Yes.
Because of diabetes.
So how is it related to viruses?
These patients are not more prone for these viruses, but if the virus gets into the individual, it produces cirrhosis much faster, and development of liver cancer is faster. What normally takes about 20 years would take 10 years in a patient with fatty liver and hepatitis C.
So there's no treatment for fatty liver?
There is treatment. There is treatment which is going on. So that could be
Good
one
afternoon.
of the next talks sometime later.
Good afternoon, sir. Sunil Arora here.
Sunil, Dr. Kent has been...
Yes, a little clarification, sir. First, I must congratulate you for serving essentially the population of Punjab. Incidentally, I belong to Moga. And you mentioned some anti-HCV Moga 9% and the Bathinda 1%. I would like to understand what does it mean again, if you can read.
Sir, 9% is out of 100 people, 9 would be harboring hepatitis C infection. Whereas in Bathinda, out of 100, only 1 would be harboring hepatitis C infection.
That means Moga is maximum affected, sir?
Yes.
It's rather, I would say, alarming for me.
It is alarming because, you know, the injection practices have been going on for long. The RMPs have been flourishing there. And the universal precautions for injections have not been followed there. There could be some genetic reason as well. In fact, while I was there in the institute, the entire village used to get affected with hepatitis C. So there has to be a reason why this has happened.
Well,
can I come in, sir?
Well, IBPASI must note this also. Thank you, sir.
Welcome.
Can I ask you?
Sunil, you were wanting to ask something, Sunil?
Yes, sir. Yes, sir. Thank you for this illicit talk. You know, I have been associated with you working on hepatitis C patients for many years.
So I just want to come
in
to make an observation, please.
Ma'am, just a minute. I am continuing with the comment, so you can ask later. Yeah. So we had a very productive time with Dr. Chawla when we were working, and we thought that it's a very difficult situation and over the year. What I want to comment on is regarding what Dr. Chawla mentioned about the vaccine against corona. and related to in concerned with the hepatitis C virus. The corona, as Dr. Sopti also was talking, coronavirus basically causes damage of the making of germinal centers, which does not allow the persistence of plasma cells which are long-lived and making long-lived antibodies. That's why corona patients, they don't have antibodies for a long time. But we expect that a vaccine which is given prophylactically will be able to induce proper neutralizing antibodies, and that will be protective. So vaccine may work very wonderfully in corona. So because that will act prophylactically and induce the production of neutralizing antibodies and will prevent the settling of coronavirus, which can cause damage to the lymphoid cells and making of germinal centers. So both vaccine and antiviral drugs will be the answer ultimately for coronavirus. As we have the success story about the hepatitis C, I think we'll be going faster towards coronavirus control programs. Thank you for a very nice lecture, Dr.
Thank you,
Chawla.
Sunil, for enlightening us. Dr. Dua, you had something to ask.
Nice presentation right from the history of Nobel Prizes. You said that there are 8 genotypes, and number 3rd is the most virulent form because of a particular locus. There is a simultaneous origin of these 8 genotypes, or they are mutated over a period of time?
That I will not be able to answer, sir, because genotype 1 is more common in Europe and US. Genotype 3 is more common in the Asian region and in Southwest Asia. So I don't know whether it's the same virus which has mutated. Possibly it is the same virus which has mutated over the time. Because
in coronavirus case, it has not mutated. They say there is a G strain coming now.
Right.
Luckily, the vaccine effect on all these strains is of same potency. That's
right.
what.
Right.
Right from the initial period, they adopted these inhibitors rather than adopt the method of vaccination. What is the basic perception in their minds in so far as the hepatitis C virus is concerned? Though it's RNA and B is a DNA.
You know, the major thing with the HCV is the mutation is very fast. It replicates very fast. So there are neutralizing antibodies against the hypervariable region of the envelope protein. So आपने antibodies उसके against बनाई and the other virus tends to get mutated. I think that's the major issue.
You emphasize the role of dentist 4 or 5 times. But
Yes, sir. I couldn't hear you properly.
You have said the word about dentist 4 to 5 times.
Yes.
Are you spreading this awareness among the dentists who are graduating from PGI or in the different parts? Every second shop in Chandigarh is a dentist.
Yeah. We have these, see, the dental associations hold programs on awareness of hepatitis C. The classes in PGI also tend to tell the students about its importance. Awareness has grown significantly, but you have different types of dentists working outside. It may not happen in the cities, but you have villages also where there is no quality control on the dentists working there.
Yes, right. Thank you very much.
Thank you. There is a very interesting in the chat box from Dipanshu Man. Are you there, Dipanshu Man? Please unmute yourself, otherwise I'll ask the question. Dr. Saab, the question is, why don't we limit down the expression, down-regulate the level of the virus, even if it enters the cell and expresses the protein?
I think this is purely a question which a molecular person should be able to answer.
Yes, sir. This is my very question. Actually, it's a very nice talk delivered by you. we are living in a time of pandemic. So be it is a coronavirus or be it in a HCV or any other virus, if we able to find a solution, if the cell, how a virus enters inside a cell or how it expresses itself, take over the host. So if we can get to know about the how the virus enters inside the cell, or if we manages to block the entry of the virus or block its translation process, so that it will not express itself or we will not have the disease state of in our
Since
body.
you have asked the question, it's more clear to me. You know, you take the example of hepatitis B virus. It enters the hepatocytes and there are a number of receptors. So you can block the entry of the virus by way of receptors. And there are drugs which are coming up. We were incidentally at PGI also looking at the receptors for hepatitis C entry into the hepatocytes, but no drug was came out because to attack the receptors or the entry of hepatitis C into it. But there's a good drug which has shown some success with hepatitis B. So I fully agree with you. Entry is important. If you can inhibit during the translation, there are many drugs in hepatitis B where you dampen the translation process. And for hepatitis C, they have looked at the replication. If you can stop the replication, the results would be excellent. And that is what is happening with sofosbuvir and ledipasvir, the key drugs for hepatitis C treatment.
Yes, sir. Replication also plays a very important role here in case
That's
of viruses and any other microorganism,
That's
which
right.
able to enter inside the host cell and expresses itself.
Very true.
Nice talk. Thank you, sir.
Thank you.
Thank you, Professor Chawla.
Yes, ma'am.
Time for one last question.
Right.
If there is anybody from there, otherwise there is Ayush Jain.
Madam P. Amit Kumar, Madam.
Amneet Kumar, can you please unmute yourself? Amneet? She's not there.
Yes, madam, I'm here. I'm here,
Okay.
ma'am. Thank you for giving me the opportunity to contribute. This is a wonderful opportunity for all of us to benefit from such an elevated talk. I would like to just share with the participants that Haryana government has been working on the evidence-based data collection regarding the hepatitis prevalence, and our 4-5 districts bordering Punjab, particularly Sirsa, Fatehabad and others, they are heavily impacted. And around 4 years back, Haryana became the first state to come out with a policy document and have a scheme exclusively for free testing facility and also for full dose treatment. We have collaborated with Mylan and provided this treatment free of cost to our people up to the PHC level also now. So in May 2020, our government has initiated the vaccine also. So the availability is going to be up to the PHC level, so that at the point of care, the availability can be there for all the civil or the patients. Another thing I would like to highlight is we have associated ourselves with various NGOs also who go and hold talks with various stakeholder groups like barbers, like RMPs, and people who use needles and syringes, who are drug addicts also. So they are being sensitized and told about the methods in which this perpetuates, and also how to control and avoid the transmission also. So thank you for letting me brief the house. And I would request everybody to have a look at the Haryana model. And if anybody wants to visit, kindly let us know. Thank you.
Thank you, ma'am.
And
Vaccine, you meant hepatitis B vaccine, huh?
so we can have more questions a little while later, but I would now request Professor Sopti to give concluding remarks. Professor Sopti.
Sopti, are you listening?
Professor Sopti. He may have left. He already gave a bit of remarks. So now Professor Bagla, would you like to say something? Professor Bagla is from ISER Mohali and he's one of our associates for today's lecture. Professor Bagla.
He is also not there.
Yeah, he's there. Professor Bagla, please unmute yourself.
Yeah, thank you, Professor Kayadharambir.
Yeah.
I would like to thank everyone, first and foremost, Professor Yogesh Chawla for the wonderful presentation and response to all the questions and comments, and SPSTI for putting together this nice program. This is just the first part in the series on all the Nobel Prizes for this year. Professor Kayadharambir, Dhambirji, Professor Arun Grover, who has been the driving force in putting together this entire series, and of course the contributions and help from NASI and ISA Mohali. Staff at SPSTI who has been coordinating the Zoom session and making sure that everything runs smoothly, and all the wonderful participants. So I just want to say thank you to everyone. Thank you very much.
Thank you. Thank you.
Thank you, Professor Bagla. And if now Professor Chawla has 5 more minutes, we can take some questions from the Facebook.
Sure, ma'am.
Anuj.
Sorry, ma'am, there are no such questions from Facebook. We have Professor G.S. Cat who wanted to ask something earlier.
Can साहब तो बोल चुके हैं. So now Ayush Jain, if you are there, you can ask. Otherwise, I will read out your question. Ayush Jain has asked.
Yes, Ayush Jain has been unmuted.
Okay, Ayush Jain, would you like to ask your question?
Hello.
Yes.
Yes, ma'am. So a very good talk, sir. I just wanted to ask, what are the strategies for vaccination has been already used for making a vaccine in hepatitis? Although we are not able to come up with a very good vaccine, but I just wanted to know what strategies already have been used.
No, I think these strategies have. There was the hepatitis C vaccine is nowhere in sight, so there are no strategies. And if at all they develop strategies, they would be piggyback on hepatitis B vaccination program, which is going on in all over the country. So hepatitis C would not be given to the infants or children because it doesn't exist there. It would have to be given to the high risk group to start with, and then identify the households who are having HCV positivity and those who are staying with the person who's HCV positive. There are no strategies as yet, but probably it would piggyback with what is happening with hepatitis B.
So, sir, can we use strategies like currently what we are using or we ought to use for coronavirus? One such strategy is like creating an artificial virus-like particle using different viruses which we know are disarmed virus, which vectors which we can use, and then put proteins of or the code proteins of this particular hepatitis viruses, and then use this particular thing to inject or safely administer to the population so that it can act as a vaccine.
No, I'm sure this type of strategy would have been worked well because the virus has been there for so many years. And before these directly acting antiviral drugs were available, there was a lot of hue and cry about the vaccine. So they've not been successful as yet. But I'm sure what you suggested, they might have tried. If they haven't, then it is worth giving a try.
Okay. Thank you, sir.
Welcome.
Thank you. And here's the last question from Deepti Gulati. She wants to know, is there any role of nutrition in reducing the risk to hepatitis infections?
Nutrition as such has not been found to be, because when you look at the lower socioeconomic status and the higher socioeconomic status, there's not much difference, except there may be very little difference between the two. But the role of nutrition in getting hepatitis C infection, I think, is not well studied, and possibly it doesn't work. Because the mode of transmission is through blood, and spontaneous clearance of hepatitis C occurs in 30% of cases. What are the factors responsible? It's mainly the immunity. And if nutrition tends to hamper the immunity, then possibly chronicity would happen more in these group of patients. But this has not been adequately studied.
Thank you very much. So that brings us to the end of this session, and a huge round of applause for the speaker as well as the participants.
Thank you, ma'am. Thank you very much.
Thank you.
Yeah,
And now we have a few announcements, so if you can stay on for a few moments, and then we switch off. So these are the upcoming lectures, and we will be announcing on our website. Anuj, please website दिखा दीजिए एक बार.
Dates and speaker.
Dates
as well. Speaker list.
So that's the website, and thank you everybody for joining us. Thank you very much, and now that's the end of this.
Our website is spsti.org.
Thank you. Thank you very much, ma'am. Thank you for the team for giving me a chance, ma'am.
Amni, thank you very much for coming. Satveer Chaudhary, thank you. Everybody else. Thank you, Grover sir.